Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. The patient in this procedure attended with a fully blocked right ear, and the outer part of the earwax was quite soft, wet. The patient had been using loads of, I believe, hydrogen peroxide drops. You can already see there's a lot of hair there, it's some matted hair, and once I remove this outer coating, this outer layer of wax, you'll see a furball. It's the best way I can describe it, a furball of earwax really impacted against the eardrum. So the patient, as you can assume, underwent the cardinal sin of using a Q-tip or a cotton bud as it's known in the UK, and really impacted the earwax against the eardrum. And the patient has got quite a narrow ear canal, particularly near the eardrum, so it was really lodged beyond this narrowing, and it's quite an ordeal to remove. So just using microsuction here, just trying to break up this wax. So the outer layer was quite soft and wet, as you can see, and already I'm going through that, and this more mid-section, mid-canal layer of wax is a bit harder. As we go towards the eardrum, the wax is getting more and more harder and solid and more matted. So the drops had softened the outer layer, but it wasn't able to penetrate any further and soften the more medial part of the earwax. When we say medial, we mean towards the eardrum. When we say lateral, we mean further away. And I'm just trying to lift this, so there's a bit of keratin here, a bit of skin as well that's in the mix. Just trying to lift it off the base of the ear canal. And these are all loose hairs. Most people have hairs in their ear, but the hairs in the ear, the cilia, that's what we call them, should only be on the outer third of the ear canal, the cartilaginous portion of the ear canal. So just some ear anatomy. You can think about the ear canal in thirds. The outer third is made up of cartilage and a thick layer of skin, approximately 1 millimeter in thickness. With it being made up of cartilage, it's semi-flexible, it's not as sensitive as the inner 2/3 of the ear canal, which I'll describe in a moment, so it's slightly malleable. And the outer third of the ear canal bears the hair follicles, from where these hair strands derive from, and it also contains 2 glands. The first is called the sebaceous glands, and they produce an oily, fatty substance. The same substance we find on our scalp, the oil, if we don't wash our hair for a few days. And they also bear ceruminous glands, which is a sweat gland, similar to the sweat gland you find under your armpit. So that's the outer part of the ear canal, the outer third. The inner 2/3, where we are now, is made up of a very thin and delicate layer of skin, approximately 15 times thinner than the 1 millimeter layer of skin that lines the outer third of the ear canal. So it's very thin. And it's tightly attached to bone. So there's no fatty tissue, there's no buffer, there's no cartilage. It's literally the thinnest layer of skin you can imagine on bone. And if you make contact with bone, it's going to be uncomfortable. So hence why we can't use an ear hook or a Jobson horn here, because it's going to come in contact with the bony part of the ear canal, because we're going to have to glide it against the canal to get in and behind this furball of wax. So the only time you can use an ear hook or a Jobson horn on the bony part of the ear canal is if the patient is a sucker for pain, they enjoy pain, or if the patient has had a local anaesthetic, which I don't perform, or they're under GA, so a general anaesthetic. So the inner 2/3 is always very sensitive. We're going to be extra cautious, and the patient already, upon attending, was describing earache, what we call otalgia. Forceps wouldn't have been really useful because there's nothing really to grab onto. I can just pull out these individual hair strands. It's not going to pull out this plug of this furball of wax. So I've just put some olive oil drops in. So the patient had already used drops, but as I mentioned earlier, the drops had only softened the more lateral layer of this furball of wax. So I've just gone back in with some olive oil, and even with the olive oil, it's still quite difficult. So where do these hairs come from? So that's where I started off by describing the ear anatomy. So these hairs shouldn't be there. as I mentioned, these hairs should only be on the outer third. So how do they get there? So there's no hair follicles on the inner 2/3 on the bony part of the ear canal. There's just no follicles there. So what's happened, this patient regularly trims the hairs on their tragus, which is a little floppy part. So if you feel your ear just on the, really against your cheek, there's a piece of cartilage there which you can flop backwards and forwards just before your ear canal entrance. That's a tragus, and the patient used a shaver to trim these hairs, and what's happened, these hairs have flown in to the ear canal. And alongside the patient using a Q-tip, the cotton bud has really impacted the hairs against the wax. And the problem with hairs in the ear canal, it just makes it very, very difficult to remove wax when you've got matted hair against it. So when you've got a matrix of hairs, it's very difficult to perform suction. So if you're watching this and you do trim your hairs on the outside part of your ears, it's not a problem, but what you need to do is get some cotton wool. You can put a bit of Vaseline around the edge if you like, and don't shove it in your ear, just position it, cushion it against the entrance, so it's creating a barrier, so as and when you do trim your ear hairs, they don't fly into the ear, and then once you've trimmed it, you can remove the cotton wool, and hopefully there's no hairs that have entered your ear. So you can see I just peeled some dead keratin off the ear canal wall, but this plug, this furball, it's still here, and I'm just at the roof of the ear canal, and the patient did find it slightly uncomfortable, and you'll see why in a moment. When I remove this plug of wax and hair and skin, the patient did bruise themselves with the cotton bud, and you'll see a bit of bruising there afterwards. Suction probe just got blocked, so I was just trying to loosen some of the wax, this furball, from the roof of the ear canal. And I'm just on the anterior part here, the right hand side of the ear canal. So on the right here, the right hand side of the ear canal, towards the nose, we call that the anterior. Where I am now at the bottom, that's the inferior, the base, and I'm just lifting that forwards, upwards, trying to rotate and manipulate this furball outwards. To the left, that's the posterior, that's the back part of the ear canal, and to the roof, another name for that is superior. So I finally managed to get a bit of a suction grip here, which is very difficult to do, especially with matted earwax, and because the wax is quite dry immediately, and I'm just lifting this upwards. You can see some keratin at the base of this plug, the white glossy layer, so I've detached that from the canal wall, and it's still slightly trapped. So in this region of the ear canal, you can probably see the ear canal narrows a bit, and then it protrudes back outwards, and we call that an isthmus. It's a natural narrowing in the ear canal, about 1/2 centimetre away from the ear canal. So this is lodged beyond that narrowing, hence why it's even more complex. I have managed to loosen this now, so I'm slowly bringing it forwards. Bingo. So that's that furball. Just going back in. So the patient's symptoms have alleviated, but I'm just trying to mop up now. And you can see the bruising to the posterior part of the ear canal on the left. You can see it's a bit red there. And just peeling this piece of skin that's got some loose hair strands matted to it off the back part of the ear canal. So there is a bit of wax still very deep against, deep in the ear canal, at the base of the ear canal near the eardrum. You'll see that in a moment, so I will get that out. And what I want to do, it's not always possible, I'm just trying to remove as many hairs as I can. These hairs, it makes it difficult because we put drops in, these hairs become really sticky, and they can stick against the eardrum, stick against the ear canal, so it is quite tricky. I could have used forceps, but I managed to remove these using suction actually. You'll see that in a moment. At the end of the procedure, all these hairs, I believe I got them all out. It's not always possible. Is it the end of the world? No. Sometimes you just leave these hairs, let them dry, and sometimes they can naturally come outwards towards the entrance, and we can remove it then at a later date. So I'm just trying to peel some dead keratin off the roof of the ear canal. You can see that's extending all the way to the eardrum, and I managed to get a few hairs that was adhered to it out as well. And you can see there's a bit of wax inferiorly. It's a very narrow ear canal, so I think this is a fine end gauge, or is it? And it's taking up much, even with a fine end, it's taking up a lot of the space in the ear canal. Actually, that might have been a standard Zollner suction probe. I think this is the fine end. This is the fine end. So even a fine end looks quite big inside the ear. So the fine end is an adaptation, a smaller, narrower suction tube that we attach to the tip of the endoscope. Not the endoscope, the Zollner suction probe. So you can see we've got all those hairs out. Really happy. Patient was over the moon. Very relieved. Well, I hope you enjoyed that video, guys. Wishing you all a great weekend. We've got a clear wax training course tomorrow, so we're having quite a few at the moment. So look forward to that. Take care and speak to you all soon.